Hi everyone, I'm Dr. Roman and I am here with another one of my educational cancer videos. And today's topic is on uterine cancer, specifically endometrial carcinoma. Now, as with all of my educational videos, I'm going to give you a lot of information, but I'm going to do so in a simple fashion so that all of you can follow along. Because let's face it, cancer is somewhat of a difficult topic, and my whole goal here is for patients and family members to be prepared so that when you go see your doctor, you can follow along and you can understand what is happening. And also, for those of you who are healthcare providers, I honestly think that you will find these videos extremely educational. So with that being said, let's get started. So as with all my videos, this is for educational purposes only. I am not providing medical advice. So let's start off with a brief overview of everything we are going to cover. So first of all, we're going to talk about endometrial cancer per se. We're going to talk about the different histologies of endometrial cancer, also risk factors, as well as symptoms that you may develop or have, the workup once you're diagnosed with endometrial cancer, and also more aggressive or less aggressive forms of endometrial cancer, as well as staging and ultimately treatment. And as with all my videos, at the end, I've come up with a list of questions that I would have if one of my family members was diagnosed with endometrial cancer. And let me remind you, I am an oncologist. I'm treating cancer patients all the time. And these are the questions that I would have. So consider writing some of these down so that your doctor can answer them for you. Now, there are different types of uterine cancer. Specifically, the one we're going to talk about here is endometrial cancer, which is cancer on the innermost lining of your uterus. And just know that endometrial cancer is the second most common gynecological malignancy globally, where cervical cancer is number one. Now, in the United States, this is the most common GYN-related cancer. So we all really need to know about this cancer. The good news is that about 80% of patients present in the earlier stages of their cancer, namely stage 1 and stage 2. And this is because endometrial cancer tends to cause vaginal bleeding or spotting. And then when women see this, they seek medical attention. So let's go over the anatomy of the uterus. So here you have the vaginal canal, here you have the cervix, and of course, this here is the uterus. Now, on the right and left, you have a fallopian tube and an ovary. All right, now the important part is that the starting point here of the uterus is what we call the cervix. So here you have your cervix. Then you have the body of the uterus, and up here you have the fundus of the uterus. And what's important about this is that the endometrium is the innermost lining of the uterus, and it is essential in your menstrual cycle. Now, when you develop an endometrial cancer or an endometrial carcinoma, depending on its location, it will start to grow and invade the uterus. So for example, here you have a cancer growing in the endometrium, and it's going to start to grow and grow and grow and invade. And whatever organs you have around the uterus, okay, like your bladder, your rectum, large intestine, small intestine, whatever organs you have around the area, that cancer can actually start to directly invade them. And that's one of the ways that endometrial cancer likes to spread. The other way that it spreads is through our lymphatic vessels or lymph nodes. So it can actually enter into surrounding lymph nodes around the uterus, and from there it can spread to other areas of the body. And this is important to know because when we perform imaging studies like CAT scans or PET scans or MRI scans, we want to focus on these locations to see if it appears that the uterine cancer is local or has it spread to one of these other sites. So now talking about risk factors or things that can increase your risk of developing endometrial cancer. They are obesity, also if you're a diabetic, late menopause, unopposed estrogen exposure, tamoxifen, also if you've never given birth to a live child, polycystic ovarian syndrome, Lynch syndrome, and complex atypical hyperplasia. These are just known risk factors, but it does not mean that if you're obese or if you're a diabetic, you're gonna develop endometrial cancer. That's not the reason I'm showing this to you. It just means that these are known risk factors, right? Now, symptoms, and this is obviously something that we all need to know about. The first one that is by far the most common and the most significant is vaginal bleeding, especially if you are postmenopausal. There's no reason as to why a postmenopausal woman is having vaginal spotting or vaginal bleeding. So if this happens, seek immediate medical attention because endometrial cancer is a possible cause. Now, pain is another one, as well as weight loss and fatigue. But I have to tell you, usually when you have these, it's because unfortunately the cancer, the endometrial cancer, is a little more advanced. So vaginal bleeding, that is the time that you really want to seek immediate medical attention. Now, the doctors that you're going to see if you are diagnosed with endometrial cancer, the first one is a gynecologist oncologist. Now, this is a gynecologist that has special training in providing surgery to women who have cancer within the uterus, the ovaries, the fallopian tubes, the cervix. So within the female reproductive organs, this is a surgeon that is trained to perform this type of surgery. And it's important that you know this because gynecologists, oncologists, in having special training, are really good at performing these surgeries. And for the most part, patients tend to have better outcomes if they are having their surgery performed by a gynecologist oncologist. Now, there are surgeons out there that are not gynecologists oncologists that perform a lot of these surgeries. So, the reason I'm bringing this to your attention is just make sure that whoever your surgeon is, they have a lot of experience in performing these types of surgeries. The other doctor is a hematologist oncologist. For example, that's what I am, and we provide chemotherapy, immunotherapy, etc. Now, I do want you to know that there are some gynecologists oncologists that can also give you chemotherapy. So just something to keep in mind. And last but not least is a radiation oncologist, and these are doctors that provide or give you radiation therapy. Now, the workup. So when you're diagnosed with endometrial cancer, we want to perform laboratory studies. We want to perform a CBC because we want to look at your white blood cells, your hemoglobin, and your platelet count. We want to make sure these are all appropriate because, for example, if you have anemia, we want to try to address it. A lot of times women with endometrial cancer, because of bleeding, may have iron deficiency. Anemia. So if your iron is low, we want to address that. The other thing is what we call a CMP, which stands for a complete metabolic panel. We want to look at your kidney function, your liver function, your electrolytes, like your sodium, potassium. We want to make sure these are all good. Also, tumor markers, which the main tumor markers for endometrial cancer is your CEA and your CA125. Now, I want to take 1 minute to talk about tumor markers. First of all, these tumor markers, which are simple blood tests, are very non-specific. You may have endometrial cancer and have normal tumor markers, or you may have these tumor markers elevated and it be due to another cancer because other cancers can also elevate these tumor markers. So again, I want to stress the point that they are very non-specific. Now, they're quite useful, especially, for example, if you have an elevated tumor marker. So let's say your CEA and your CA125 are elevated, and I start you on treatment and your tumor marker starts to come down, then it is highly suggestive that you are responding to treatment. By that same token, if your tumor markers were elevated and they came down with treatment, and all of a sudden they're starting to come back up, it's highly suggestive that maybe your cancer is coming back. So that's usually where we use these tumor markers. Now, the other thing here are imaging tests. And these are pictures that we want to take of your body to see if this cancer has spread beyond the uterus. For example, you can have a CT scan, also known as a CAT scan, of the chest, abdomen, and pelvis, or a PET scan can be done, or a pelvic MRI scan can be done. The bottom line here is taking pictures to try to figure out how advanced your cancer is. And last but not least is an endometrial biopsy. Think about it. If you have something growing in the uterus or if you're bleeding, we want to take a sample of it to see what is it. The first question is it cancer? And the second question is, if it is cancer, which cancer do you have? Because there are many different types of cancer. All right? Now, continuing to talk about that biopsy, obtaining an endometrial biopsy, there are different ways that we can go about it. The first one is a blind biopsy. We just put an instrument inside the uterus and blindly take a sample. The other way is through a camera, a hysteroscopy. The good thing about the hysteroscopy is that you're actually visualizing the inside of the uterus. The bad side of it is that it's a little more labor intensive because it takes more instrumentation. You need to go to a doctor that has the camera. It's more expensive. So again, it's a little more labor intensive, but it can be a little more precise. So question is which type of biopsy you're going to have. A very common biopsy is what we call a DNC, which stands for a dilation and curettage, where they go in there and they basically, with an instrument, and they scrape the inside of the uterus and they send this out to the laboratory for testing. So that's a very common method that we employ in diagnosing endometrial cancer. Now, notice that I definitely want you all to know this because I've seen a few patients tell me this. And what I want you to know is that a pap smear, may miss well over 50% of endometrial cancers. Remember, pap smears are for cervical cancer. And I've seen a few patients with cancer of the uterus or an endometrial cancer tell me, I was bleeding, but I ignored it because I had a normal pap smear and I thought I could not have endometrial cancer. Just know pap smears are for cervical cancer, not endometrial cancer. You can have a normal pap smear and still have cancer of your endometrium. Very important. Now, moving on to the different histologies. So remember, when you obtain a biopsy and they tell you it's endometrial cancer, it can be several different types of endometrial cancer. Now, the most common, seen in over 80% of cases, is what we call an endometrioid endometrial cancer. It's important you to know because endometrioid tends to be better. They tend to have a better prognosis. Now, endometrioid can be either grade 1, grade 2, or grade 3. This simply means that when they look at it under the microscope, the higher the grade, the more aggressive it appears to be. So for example, a grade 1 is lower grade, then grade 2 is a little bit higher, and grade 3 is a higher grade or high grade endometrioid cancer. So you want to know not only the histology, but the grade. Then other types of histology, for example, is serous, which is seen in about 10% of cases, as well as clear cell and carcinosarcoma, which are much less frequent. Just know that serous, clear cell, and carcinosarcoma tend to be more aggressive. All right. You can also have another type, which is a mucinous type endometrial carcinoma, but this is extremely rare. And I also put this histology on here, which are sarcomas. Just know that sarcomas are tumors of the actual muscle of your uterus. So this is not endometrial cancer, but I threw it on here just so that you know this is why it's so important to obtain a biopsy, because you have many different types of histology. But what we're talking about in this video, which is endometrial carcinoma, it can either be endometrioid, serous, clear cell, or carcinosarcoma. These are by far the most common. But again, the clear cell and the carcinosarcoma is very uncommon. All right, so moving on. Now, what's important to know, once you've been diagnosed, and this is common sense. If you've been diagnosed with endometrial cancer, the next question is, okay, now do I have an aggressive form of endometrial cancer or a less aggressive form? And less aggressive markers are, for example, if you have grade 1 or grade 2 disease. So if your pathology result tells you grade 1 or grade 2, or if they say low grade, then obviously that is good. It's better. If they tell you it's endometrioid histology, that is better. If it's mucinous, which is very rare, but mucinous tends to also be better. And I threw this on here. I don't want to confuse you, but if you had surgery and you look at your actual surgical pathology result, okay, once you have surgery and they remove your uterus, they will tell you, or they should tell you, if you have lymphovascular space invasion, called LVSI. And if they tell you there is no LVSI or focal LVSI, that is better. Okay, now let's move on to the more aggressive. Now, for aggressive disease, of course, anything that is grade 3 is more aggressive. So if your pathology result says grade 3, it's more aggressive. If you have serous histology, if you have clear cell histology, if it says mixed, or if they use the word undifferentiated, if they say you have carcinosarcoma, all of these are more aggressive. If you have mesonephric-like endometrial, if you have gastrointestinal type mucinous, it's different from the just plain old mucinous. If they tell you gastrointestinal type mucinous, it's more aggressive. And again, if they tell you you have diffuse LVSI, contrary to the no or focal, then diffuse is obviously more aggressive. So again, I'm not saying this to scare you. I'm telling you this because you really need to know if you have a more aggressive form of disease, because what do you think that's going to do to management? That's right. We're going to be more aggressive with you. And that's why we want to know all this. Now, the staging. This is also crucial to know your stage. If you think about it, this will tell us how advanced your cancer is. And obviously, the less advanced it is, the better. So for example, endometrial cancer is divided into stage 1, 2, 3, and 4. Just know that stage 1 is the earliest form, whereas stage 4 is the most advanced stage of endometrial cancer. Now, of course, as with everything in cancer or oncology, everything is complicated. Now, I'm going to try to simplify it here, and obviously I cannot go into such detail because I will simply lose you. But just know that in stage 1 disease, it means that your cancer, your endometrial cancer, is confined to your uterus. So it is only there. Now, stage 1 is further subdivided into A, B, and C. And of course, A is earlier stage than C. So they can tell you you're a stage 1A or stage 1B or stage 1C. Each one meaning it's a little bit more advanced within the uterus. Now, stage 2, as an example, means that the disease has spread to the cervix, and it can also have spread to other areas. But again, it's beyond the scope of this presentation where I'm trying to keep it simple. And stage 2 is further subdivided into A, B, and C. Then stage 3 is even more advanced, where you have now local spread of the cancer. So now you have cancer within the pelvis. And again, stage 3 is already known as a more advanced stage of disease, and it's also further subdivided into A, B, and C. And then last but not least is stage 4, which is the most advanced form, where if you have stage 4A, it means that it has perforated, went through the uterus. Remember when you refer back to the anatomy slide, and unfortunately it started to invade your bowels, so your intestines or your bladder, and or a stage 4B, which means you have distant metastasis. As an example, maybe the cancer went from the uterus through the lymphatic vessels, remember your lymph nodes, and now you have it in your liver, or you may have it in your lungs, for example. That would be a stage 4B. So obviously, when you meet with your doctor, ask them, which stage cancer do you have? All right, I need you awake because this is something that is new. This is fairly new in the field of oncology, and it's very important that you know this. And this is the molecular classification of endometrial cancer. So in the past, we did not look at this. We did not even know about this. But now we know that different endometrial cancers behave differently. Some are better and some are more aggressive. And we found out that knowing these markers is crucial in trying to understand if your disease is going to behave a little bit better or if it's going to be more aggressive. And these are, for example, the P53, if you have MSI high or MMRD, which is mismatch repair deficient, or if you have the POLE mutation. Some call it the POL mutation or the POLE mutation. I've heard different pronunciations, but it is the POLE mutation. So in other words, I'm going to simplify it for you. When you see your doctor, you want to know, Doc, you're going to ask, Doc, do I have a P53, my tumor? Is it P53 positive? Am I MSI high? And or do I have the POLE or POLE mutation? And the reason you really want to know this is because if you have the POLE mutation, you're going to have a much better prognosis. That is a good thing. If you have the MSI high, it's intermediate. And if you have the P53 mutation, that is not good. That means that your disease is going to be more aggressive. And again, we want to know this because we will be more aggressive with you. And last but not least, you can also have no specific molecular profile. In other words, you have none of these, in which case it will be an intermediate prognosis. So looking at it a different way, when you're first diagnosed, the question is, do you have the POLE mutation? If the answer is yes, that is good. If the answer is no, okay, well, do I have the MSI? Am I MSI high? If you do, that's intermediate risk. If you have the P53 mutation, that is not good. So again, you need to know. I'm not saying this to scare you, but just to educate you so that you know that we need to be more aggressive with you. And if no specific mutation or alteration was found, then it is intermediate prognosis. Again, just reiterating this because this is very important to know. So if you find this educational, I'm going to ask you to subscribe to my channel, check out some of my other educational cancer videos, and please leave me a comment. Let me know what you think of these videos. All right, now moving on to treatment. And let's start off with the treatment of local disease. The first thing is, or your options are going to be surgery, radiation, and chemotherapy. So let's talk about each one. First, starting off with surgery. So surgery obviously is an extremely important part of treatment for endometrial cancer. And just know that you can have either minimally invasive or open. So minimally invasive, where the doctor is going to make little holes in your abdomen. So again, these are through small incisions. It can either be laparoscopic or robotic. And that's a question for you to ask your doctor if you are a candidate for minimally invasive surgery. The other option is an open surgery through a larger incision, what we call a laparotomy. And again, the question is, are you a candidate for a minimally invasive or will you require an open surgery? The other treatment option is radiation therapy. Now, radiation can either be external beam radiation therapy, meaning through the outside, or vaginal brachytherapy. Now, brachytherapy, as I'm defining here, is basically inserting radioactive pellets or wires into the vagina, and it's a way of delivering radiation. The whole idea behind radiation is we want to try to prevent this cancer from coming back locally, okay, within the pelvis. And last but not least is chemotherapy, and together with chemotherapy, we have other options like immunotherapy. Now, talking about the treatment of local disease, and specifically in keeping with surgery, your doctor will perform a hysterectomy. In other words, obviously, since the cancer is inside the uterus, your uterus has to come out. But you are also going to have what they call surgical staging. And this means that at the time of surgery, they're going to try to clean out the area as much as possible. And they're going to try to evaluate the area because we want to make sure, or we want to try to prevent any cancer cells from staying behind. And if you do have cancer cells that remain behind, we want to know this because this will impact any further treatment we will give you. So you will have the hysterectomy, which means removing the uterus, and you will have surgical staging. Now, surgical staging simply means that your doctor will remove or perform what they call a bilateral salpingo-oophorectomy, meaning your ovaries and your fallopian tubes will come out. Also, they will do pelvic washings. Very simple. They will just put in sterile fluid around your pelvis. They will suck it back up, okay? And we will send this to the laboratory and just look to see if we see any floating cancer cells. Very important. And also, they will examine the abdominal cavity, the pelvic cavity. They will go in there with the camera or just looking if it's an open procedure, just to see if they can see any cancer cells at any other organ or any other location. And last but not least, they will also evaluate your pelvic and or your para-aortic lymph nodes. Remember, lymph nodes, which are bean-shaped structures, which are part of your immune system, these lymph nodes are all over our body. And cancer, specifically endometrial cancer, likes to go to lymph nodes. So they will also surgically remove several lymph nodes around the area just to see if you have cancer cells within these lymph nodes. So all of this collectively is known as surgical staging. Very important. And if you had surgery for endometrial cancer, find your pathology result and you should see all of this on there. Very important. All right, now I did want to mention a special situation, and this is if you are of childbearing potential and you want to have children. Obviously, if you have cancer inside the uterus, that's a problem. But just know that if your cancer is very early stage and if it's low risk, there may be the possibility of you to have a what we call fertility sparing treatment option. So again, this is seldom done, but it is an option if you are early stage and low risk. So something for you to talk to your gynecologist, oncologist about. All right, now moving on specifically to the actual treatment. We've already gone over the options. Now let's go over the treatment one by one, specifically of local disease. So if you are a stage 1A, this is the earliest form of endometrial cancer. You were lucky enough to be detected in a stage 1A, and you are a grade 1 or grade 2 endometrioid. Again, this is why you need to know the histology, the grade, because everything will influence the treatment that your doctor will give you. So again, specifically a stage 1A, very early stage, grade 1 or 2 endometrioid type endometrial cancer. Chances are you will have surgery and your doctor may recommend brachytherapy afterwards. So that is one option. Now, if you're a stage 1 or a stage 2 with the POLE mutation, the POLE mutation, chances are your doctor will perform surgery and maybe they will not do anything else. They will just monitor you. So think about that. The reason is because we already know that if you have the POLE mutation, the disease tends to be less aggressive. And that's why we need to know all this. Okay, so if you're a stage 1 or stage 2 with the POLE mutation, surgery and maybe nothing else. Although there are circumstances in which your doctor may still recommend chemo. I'm just going over just general recommendations or guidelines. Again, each case is unique and specific, so that's a discussion you have to have with your doctor. But think about it. That's why it's so important that you know about the POLE. Now, if you're a stage 1, grade 3, or a stage 2 without the POLE mutation, then chances are you will have surgery and then likely radiation therapy, for example, external beam, radiation therapy, and brachytherapy, and they may even consider giving you chemotherapy. So again, notice how I use words like consider, maybe, because there are options. So just as a quick recap, stage 1A, grade 1 and 2, endometrioid, surgery, maybe some brachytherapy, stage 1 and 2 with the POLE mutation, surgery, and most likely nothing else because again, the POLE mutation is good. And if you're a stage 1, grade 3 or stage 2 without the POLE mutation, then you will have surgery and likely radiation therapy and possibly even chemotherapy. Right? I know that's a lot of info. If you need to stop and go back, do so. But if you go to another video that they do not go over so much detail, then you will not know any of this. And that defeats the purpose. Now, treatment, continuing treatment. What if you're not a candidate for surgery? Let's say you're older, you're debilitated. Well, what about radiation therapy? That's another option. Also, we may consider giving you hormonal treatments like or estrogen blocking drugs. That's also another option. A lot of times we reserve this for patients that are a lot older. I mean, I have patients that are in their late 80s or maybe even 90s that have an advanced or have endometrial cancer. And, you know, you really have to think twice before sending a patient like this to surgery. So these are all also other options. Also, you may consider, together with the radiation, giving chemotherapy is what we call concurrent chemoradiation. This is using lower doses of chemotherapy as a radiation sensitizer. It just means giving chemotherapy to help the radiation work a little bit better. That's all that means. All right, but let's get back on track. Now, moving on to treatment for more advanced disease. So this is especially if you have stage 3 and stage 4 disease. The first thing you have to look at, once again, you have to test for biomarkers, or usually you should test for biomarkers. Now, remember, we've already tested for the POLE, the MSI, and for the P53, but there are others that we also want to know of, especially if you have more advanced disease. For example, here, once again, we see the MSI or MMR, which we already went over. Here we have another one that's called TMB. Another one is the HER2. Another one is NTRK, the NTRK mutation, and ER and PR, which stands for estrogen receptor and progesterone receptor. And let's break this down. I'm not telling you this to confuse you. It's because it's extremely important. For example, if you have the MSI high, you're a candidate for immunotherapy. The same thing with TMB. If your TMB score is 10 or greater, you're a candidate for immunotherapy. If you have the HER2 protein, you're a candidate for an anti-HER2 medication. So if you have the HER2, you're a candidate for that medication. But if you do not, if your cancer does not have the HER2, then you're not a candidate for the anti-HER2 because it's not going to help you. So why give you a medication that's not going to help you? The same thing with NTRK and the same thing with estrogen receptor and progesterone receptor. So now if you have, again, stage 3 or stage 4 disease, you have many options. And the options include either surgery first, followed by chemotherapy and possibly other treatment options like immunotherapy. That's one option. Or they can give you chemotherapy first, try to shrink your disease, and then take you to surgery. That's another option. And you may also be a candidate for radiation therapy. So as you can see, you have many options, and this is why it's important that you know about all this so you can have that discussion with your doctor. So as an example, if you have an advanced form of endometrial cancer, maybe a better option will be to receive chemotherapy first, try to shrink up the disease, and then go to surgery. Because a lot of times, even with advanced disease, your surgeon will want to clean you out, if you will. It's what we call a debulking, where they try to get rid of as much of the cancer as possible at the time of surgery. And if you can imagine, if you have a lot of cancer to begin with, if we can shrink it up with chemo first, then it might be a better or easier surgery afterwards. So again, many options and something that you have to discuss with your doctor. Now, the chemotherapy options are many. For example, by far the most common chemotherapy regimen that we use for endometrial cancer is a combination of carboplatin and paclitaxel. These are 2 chemo drugs given at the same time on the same day, and it works fairly well, and it's the backbone of endometrial cancer chemotherapy treatments. Now, a lot of times we can give you, again, the carboplatin and the paclitaxel together with immunotherapy. Or we can give you the same chemotherapy with trastuzumab if you have the HER2 protein. This is why it's so important that you test for the biomarkers that we already went over. Also, another option would be carboplatin together with paclitaxel and another medication called bevacizumab. So as you can see, many options. Also, I put on here others because there are other chemotherapy regimens, not just carboplatin and paclitaxel, that we can give you. Again, a discussion between you and your doctor. Also, there are several immunotherapy options like dostarlimab, pembrolizumab, durvalumab, and there are others. These are all different types of immunotherapy that you can have the discussion with your doctor if you are a candidate. And if you are, which one are they going to give you? Now, what about recurrent disease? This simply means that, unfortunately, your cancer came back. Well, First of all, if your cancer came back, we can treat you with any of the prior regimens or treatment options that we went over on the prior slide, especially if you received, for example, carboplatin, paclitaxel, and immunotherapy, and your cancer came back after 6 months or especially a year, then we can treat you with that same combination. That is one option. Another option is changing treatment altogether, and we can give you other chemotherapy options like liposomal doxorubicin, cisplatin, cabozantinib, Lenvima or lenvatinib, docetaxel, topotecan. Again, many different options that you can have. Just know that I also want to mention that sometimes in advanced disease, your doctor will give you chemotherapy together with, for example, immunotherapy or trastuzumab, and after chemo, they will leave you on maintenance immunotherapy or some sort of a maintenance treatment afterwards. Just telling you this because your doctors may actually mention this to you. Now, going back to the biomarkers, remember, notice how I've mentioned biomarkers several times, and that's because it's very important. So here you have several options depending what the biomarker testing revealed. So, for example, remember the MMR? Well, in this case, if your MMR-P, which stands for proficient, you're a candidate for a combination of lenvatinib and pembrolizumab. That is one option. If your TMB, remember we went over the TMB, if it's high, you're a candidate for immunotherapy like pembrolizumab. If your MSI high, we've already mentioned several times, you're a candidate for immunotherapy. If your HER2 is positive, remember the HER2 protein, you're a candidate once again for trastuzumab. If your NTERK is positive, you're a candidate for these medications. If your estrogen receptor and or your progesterone receptors are positive, you're a candidate for hormonal therapy. Just know that I put low grade on here. That is because hormonal therapy usually works better if your tumor is low grade. Remember, grade 1 or grade 2. That's why it's important that you know all these things, all right? So the teaching point from this slide is you really want to know what your biomarker results are or your mutation testing results are, because if you have one of these, then you're a candidate for these treatments. And if you do not have it, then we are not going to give you the treatment, because think about it. You're not going to get the benefit, but you are going to get the toxicity. So we're not just blindly going to give you one of these treatments. We want to know if we really think that you are going to benefit. All right, now we've gotten to the last slide, and these are the questions that I would have. The first one is, what imaging test am I going to have? So if you've been diagnosed with uterine cancer or endometrial cancer, am I going to have a CAT scan, PET scan? Obviously, I want to know how advanced is this cancer? What type of biopsy am I going to have? These are all questions you're going to have, of course, with your for your doctor. Also, what histology do you have? Remember, endometrioid, serous, carcinosarcoma. Is it a clear cell carcinoma? Very important. Remember that endometrioid is better than, say, serous, clear cell, or carcinosarcoma. Also, what grade is your tumor? Is it a high grade or a low grade? Low grade meaning grade 1 or 2, high grade being grade 3. Very important question. Also, what stage of cancer do you have? 1, 2, 3, or 4? Very important. Do you have the POLE mutation, the POLE mutation? Yes or no? If the answer is yes, that's better. Are you MSI high? If the answer is yes, that's intermediate. Do I have the P53 mutation? Because if you do, then that unfortunately means it's more aggressive. And that's okay. We need to know this because now we are more aggressive in your treatment. Also, what treatment are you going to receive? Surgery. Are you a candidate for minimally invasive? Do you need an open surgery? Okay. What about chemo? Are they going to give you the chemo before or after surgery? What about immunotherapy? Are you a candidate for radiation therapy? Remember, the external beam or the brachytherapy. I guarantee you that now that you're hearing this for like the 5th time, on this slide, things are starting to make sense to you. And that's why I tell patients, give the video a chance, because honestly, you really need to know all this. And last but not least, will you be tested for biomarkers? Remember, when you have more advanced disease, you also want to test for the other biomarkers, not just the POLE or the MSI. You also want to look for the NTERK. You also want to look for the HER2 because these also have treatment implications. All right? And that's it. I hope you found this useful. If you did, guys, shoot me a comment. Let me know what you think. I really enjoy reading your comments. I also want to learn from you. So consider checking out one of my other educational videos, and all the best to you.